Hi everyone, thank you so much for coming to watch this video of my presentation. So our original plan was to live stream this, however we had some technical difficulties with the Wi-Fi and couldn't quite get it started. So I'm going to be talking through the first couple slides of just some base information before getting over to the video. All right, so my presentation was considerations for a trauma-informed practice in music therapy. And the purpose of this project is to provide music therapists with information about childhood trauma and considerations for implementing this kind of care in order to expand the scope of practice. We'll look at a couple interventions and approaches to use in your own work as well. There's also a ton of board certification domains that you can hit on through this work. I'm not really going to go over them because that would be very boring and would probably take me over an hour. So just a little bit about me. I'm a graduate of Arizona State University, and I spent 2 practicums out of 5 semesters working with individuals in a domestic violence shelter. I did the first with the kids and the second with the women. And that's where I started to learn about the trauma cycle because, we'd have these kids coming in who had witnessed domestic violence or who had witnessed drug abuse, neglect, experienced that kind of thing themselves. And then talking to the parents the next semester, I would learn that oftentimes the very same things that they were experiencing at the hands of their abuser, they'd also experienced growing up from a caregiver or a parent as well. And so it really kind of developed my passion for working with trauma and specifically domestic violence survivors. And then I got to intern at the fantastic Riley Hospital for Children here in Indianapolis. I spent 6 months covering just about every inch of that hospital, which was awesome. And I learned about trauma-informed care when my supervisor, Lauren, sent me an email saying, hey, you should tune into this grand rounds this morning. It's proven to be really interesting, and skip the morning meeting. And I went, sure, okay. And it was this physician talking all about trauma-informed practices, specifically with hospitalized infants. And I went, whoa, what? There's a whole approach for this? And I had no idea. And I looked it up, and turns out there are several music therapists who operate under this framework and texts available. However, there is very limited research. So I went and I did this whole huge project on trauma-informed care as part of my internship. I think my paper was something like 75 pages, and just really developed a huge love for it there. And now I work for Bridges of Indiana, which serves individuals with intellectual and developmental disabilities on the Medicaid waiver. And when I was transitioning over to this job, I thought, I'm really not sure how much of this I'm going to be able to use in my day-to-day work at Bridges on the waiver. I'll keep up with my continuing ed, but I don't think I'm going to be able to do a lot with trauma-informed care until I work into a trauma-specific setting. And I really could not have been more wrong. Not only did I get referred to kids and adults who have experienced trauma, but a lot of it is very applicable to some of the work I've done with kids who have experienced no trauma at all, who have very supportive families and caregivers around them, especially when it comes to emotional regulation and social interaction. So I live in Indianapolis with my dog and my fiance, and I've since completed a certificate in trauma-informed practices from the Trauma-Informed Creative Arts Therapies Institute. If you'd like to contact me to learn more about that course, I highly recommend it. I will also put a link to the continuing education in the description as well.
Okay, so the first thing I wanted to talk about was adverse childhood experiences and trauma. Now this can be a really difficult topic for some people, so I wanted to take this moment to ground ourselves. If at any point you feel overwhelmed just hearing about trauma, then I will not be offended in the slightest. Feel free to leave the room. So we're just going to take a quick break here, and placing your feet on the floor, or maybe your hands on your lap or your chairs, feeling grounded And if you like, you can close your eyes or just have a soft gaze down or forward, taking a deep breath in. And then in your own time, exhaling. And we're gonna take a few deep breaths here together, just grounding down, feeling the energy from the floor beneath you, just centering you for what needs to be, focused on what's important. And so in your own time, just taking a few deep breaths. And then one last deep breath, and on the exhale, opening your eyes. All right. Okay, so adverse childhood experiences. For some of you, this might be repetitive from one of the presentations this morning, but it's defined as any toxic, stressful, or traumatic event that happens to someone before the age of 18. So it's not talking about, oops, I forgot my homework and now I'm gonna get a 0, or anything that happens stress in day to day, because that can actually be positive stress, because it can teach us maybe we shouldn't have left our backpack at home, especially when it's supported by positive caregivers as well. And so when the CDC first did their study, I believe in 1996, talking about the long-term effects of trauma, they categorized it into 3 groups. There was abuse, which is sexual, emotional, or physical; neglect, physical neglect, so not having your needs met; or emotional neglect, which is just not being present for a child, or not having their social needs met. And then parental dysfunction, which included things like incarceration, caregiver domestic abuse, witnessing that, family mental illness. But throughout the years, we've realized that there's a lot more that can cause trauma in children. So there's also separation from family, and that can be institutionalization. I know the attachment presentation today talked a lot about that as well. That can be very traumatizing for a child to be removed from their home and from the people that they know. Community violence, this is things like gang violence, drive-by shootings, school shootings. Being in an institution or a hospital long-term can also be traumatic. The death of a loved one. I know another one that's come up recently is members of the LGBT community being kicked out of their homes or isolated from their communities as a result of who they are. That can be very traumatizing for a young person to experience. There are a lot of long-term outcomes for ACEs. The first and foremost is that it alters our brain structure all the way down to our genes. Kiddos who have experienced trauma show less development in their prefrontal cortex, which is the center for logic and reason. They have a heightened stress response as well, so heightened cortisol levels. There's an increase of risky behavior as well, and this doesn't just include, maybe trying drugs or abusing alcohol. This includes things like truancy or delinquency. And so I've heard, a lot of people say, well, yeah, of course there's going to be these kinds of outcomes if that's the environment they've grown up in, that's what they've learned. But there's also a lot of health outcomes at its core too, things like heart disease and stroke later on in life, autoimmune diseases even, which kind of ties back to altering our genes. So when your body is physically attacking its own cells. Cancer as well. There's an increased risk for addictive behaviors, which does include drugs and alcohol, but also things like overeating or self-harm behaviors as well, and an increased risk for mental illness and suicide attempts. And if I'm going too fast, please feel free to ask me to go back to the last slide. So this is a chart that I believe is on the CDC's website, and it's awesome. So all the dots that are on the graph right now are kind of anyone's baseline risk for any of these behaviors or mental health. And so right now, the ACE score is at 0. This is the baseline risk for someone who has had no adverse childhood experiences. This is that risk when they've had 1, 2, 3, and 4. Suicide attempts go up by 12%. I think alcoholism goes up by about 6. You see it increase exponentially in many cases. Just the long-term outcomes, when not supported and encouraged, can be really quite detrimental. This is another image I found courtesy of United Way, and here's what people would consider to be a healthy brain, so someone with no ACEs. You see a lot of activity in the prefrontal cortex, pretty even activity throughout in the temporal lobes, which manage emotional regulation. And then you see the brain of a kiddo who I believed had been abused and neglected in an orphanage. And you see a lot more lowered activity in the prefrontal cortex, pretty much no activity in the temporal lobes, and very heightened activity in the back of the brain, the midbrain, which we'll get into in a sec. So trauma is not just for kids. I think all of us know that here. While ACEs have the most developmental impact, trauma can happen at any age. There's a lot of traumas that we talk about very frequently, such as veterans who come home and experience PTSD as a result of their deployment. With the Me Too movement, there's been a lot more talk of sexual assault and harassment and gender-based violence as well. It can also include things like death of a loved one, loss of property or loss of home or job. Natural disasters, even politics, can be traumatizing. Who knew? Adults are also at risk for secondary trauma, and secondary trauma is when you've witnessed a trauma or, as a clinician, are hearing about that trauma. Caregivers especially, there have been studies that show that somewhere between 10 to 20% of caregivers of medically fragile children meet the clinical criteria for PTSD. Older adults, too, can also experience trauma responses through things that we normally associate with the aging process. Oh, grandma's forgetting things, so we're going to move her into a nursing home. Forgetting that can be a really rough transition to move out of the home that you've lived in for potentially years as well. Loss of functions and independence, medical procedures as well, can be very traumatizing for someone if not properly supported. So now that we've gotten through all that trauma talk, I'm just going to invite everyone to take a few quick cycles of breath with me again. Just if you want to close your eyes, feel free, or ground down. And in your own time, just breathing. Taking one last inhale, and on the exhale, opening your eyes. Okay. Before I keep going, are there any questions that anyone has so far? Because I just threw a lot of information at you. Yes?
The graph you had before that had like 1, 2, 3, 4, was that number of incidents or over spans of years?
It could be over spans of years. It's the number of adverse childhood experiences they've had. So if, one might be, okay, they've had parental abuse, and then might be parental abuse and then parental separation or things like that. It just compounds. Anyone else? Okay. I don't think I need to read the first bullet point. I'm pretty sure we all have it memorized by now. So we add, as music therapists and other creative arts therapists, we add a very unique dynamic to treatment because we tap into parts of the brain that aren't strictly used in verbal psychotherapy. For example, language is processed in the Broca and Wernicke's area of the brain. But I think a lot of us know this, music taps into every side of the brain, just about every part, from the motor cortex, our occipital lobes, our sensory functions, our centers for logic and reason, just everywhere. Engagement in music has also shown to affect brain structure, behavioral and cognitive skills, and provide opportunities for emotional regulation and expression, all of which are huge goals in trauma-informed care, and increase these feelings of safety with a very trusting therapeutic relationship that we build over time. Like I said, they're brain-wise. It's compatible on research with traumatic experiences and the brain. So this includes externalization. So this is through visual means, musical play, and movement. It can help shift trauma from the present to the past. So, but however, we as therapists should encourage the containment of these experiences rather than catharsis of raw emotions. When I was in internship at Riley Children's, I was working with this 10-year-old client, really, really sweet girl, and she was brought into the hospital with a virus that paralyzed her from the waist down, and she had a tracheostomy to breathe, so talking for her was near impossible when she was on the ventilator. So we did a lot of music play to express communication and feelings, and her favorite game was to take these stuffed animals and act out a scene with them, and then the other person would have to guess what they were feeling or what was going on. So she takes them, and the little scene went like this. I think it was Animal A and Animal B were playing, and all of a sudden Animal A falls over. And Animal B, kind of bobs around like it's crying and starts to walk away, and Animal A pops back up, and then they celebrate and they hug. And when we talked about it, I asked her, so what was going on? And she wrote out on the board that Animal A just tripped and fell over, was kind of stunned, and Animal B was afraid that that animal had died and was very scared and very upset and was going to go tell someone, and then it turned out that they were okay and everything was going to be all right. And I knew, looking at her charts, that about 2 weeks before she came into the hospital, she had witnessed her mother overdose. And so I went, oh my goodness, how do we explore this? And I tried to see if, I asked her, have you been scared for someone before? And she said, no. And I was like, oh gosh, but I didn't want to push it. And I went to my supervisors and what else could I have done to get her to, open up about this? And they all said, Katie, that was it. You didn't have to do anything else, because if you had pushed and prodded to try to get that information out of her or to explore, open up about this trauma that she might have been expressing, it could have been very damaging to the therapeutic relationship and could have, in turn, re-traumatized her. So it's great that kids can explore these things through music, but just recognizing that they've done that, not pushing any forward past that, unless they choose to volunteer that information. Sensory processing is another one. Music interventions not only serve as a catalyst for an exploration of emotions, memories, and thoughts, but they also provide multiple sensory experiences: visual, auditory, tactile, vestibular. It helps clients push past the emotional numbing that can sometimes occur with trauma experiences. Right hemisphere dominance. In children's early interactions with caregivers and parents, the right side of the brain is particularly active. And if these interactions are positive, then it sets up the neural wiring for healthy relationships later on in life. However, the opposite is also true if these interactions are not supportive or not positive as well. It's possible, however, because the brain is so plastic, to rewire these connections and with proper supports from supportive caregivers and staff. Arousal reduction, which is increasing affect regulation, and their central goals in trauma. Music therapy can be used to activate the body's relaxation response, either through things that you would typically associate with relaxation, like guided imagery or maybe some yoga, to just singing and playing music, doing adapted lessons, things that they like and feel relaxed about. And then relational aspects. Music therapy is an inherently relational therapy because we use mirroring, sharing, interactive play, the therapeutic relationship and other dynamics to build on that relationship together. So trauma-informed care, it's defined as an organizational structure and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma. It emphasizes physical, physiological, and emotional safety, and helps survivors rebuild a sense of control and empowerment. So trauma-informed clinicians, we emphasize knowledge of how the mind and the body respond to trauma, and that includes a neurosequential approach to reinforce safety and arousal reduction, which I'll talk about a little later. Recognize that symptoms are maladaptive coping strategies and not pathology. Something I've noticed in my work is that there are clinicians out there who can be very quick to diagnose. Oh, not focused, ADHD. Oh, you're not listening to me, oppositional defiant disorder. But looking at the behavior and saying, what do you need? Or how can I support this, before trying to offer it up as a diagnosis? Just because they show behavior doesn't necessarily mean they have a diagnosis as well. It acknowledges the client's cultural sensitivity to values, their perceptions of illness and treatment, which we're also going to get into, and maintains the belief that clients cannot just survive the traumatic experience, they can thrive, they can be resilient and move past it all. We build on the client's strengths, we use that, I'm sure as all music therapists do, to further the treatment goals and the treatment plan and ultimately their success in the long run. There's some themes in trauma-informed care too, such as maximizing, like I said, physical and psychological safety. It requires a type of safety. You can increase this by being just a supportive person and giving opportunities for control as well, because often a theme in trauma is that loss of control. Identify trauma-related needs of children and families, such as their coping abilities or their skills, if the family happens to have any trauma history themselves. If you're in a hospital or working in some sort of institution, then predicted length of stay, to see what kind of level of care they need. Do they just need some coping skills? Do they need normalization in the setting? Do they need family support? What do they need? Supporting positive relationships and minimizing disruptions to familiar and positive figures is so important for both the child and the family as well. Encouraging resilience not only for the child but for the family. Intervention should be strength-focused, and incorporating positive caregivers, if you can, into the sessions is so great, and also gives them a way to utilize these practices when you're not in the session. Let's see. Enhancing the well-being of those working in the system, so just being mindful of how some of these things can really impact people long-term, conscious of your own experience and emotions so as not to transfer them into the session for sure. People being served can also provide a unique feedback on the services. I'm always very big on not assuming what a client needs or what their family needs, but getting feedback from them, having them have input in their treatment plan. And then consistently communicating with allied professionals. So if you're working in a hospital, that may be physical therapists, child life specialists, myself on the waiver. I do a lot with rec therapists, behavior specialists, sometimes ABA therapists as well, to develop an appropriate treatment plan and to make sure that we're all on the same page to help this person grow consistently. Excuse me. So it's, in short, trauma-informed care is strengths and resilience based. And we assist clients and families with emotional, interpersonal, physical, and cognitive issues that have arisen due to trauma. There's a lot that you can touch on through this. All right. So in doing my research on this as an intern and now as a professional, I've kind of noticed 4 main considerations for trauma-informed music therapy. Ethical, musical, cultural, and personal considerations that are all very essential in this practice. So ethical, a lot of this is pretty much standard by the book things that you see from the AMTA Code of Ethics. We have to adhere to ethical standards set out by the governing organization. And then information has to remain confidential unless the client is in danger to themselves or others, and then reported to the appropriate personnel. I know when I was at Riley Hospital, that would be the patient social worker. Now that I'm on the waiver, that's their case manager and my supervisor. I file an incident report. Adapting therapeutic methods to what they need in that moment. We all know it, the ISO principle, something that we use just about every single day with our clients. Letting them have that control and to feel that they have a choice. Using techniques grounded in the most solid research possible. Best practice doesn't mean that the approach is proven, but it's emerging in the field and showing reliable outcomes in what limited research is available. Trauma-informed care is very much a best practice because we're still researching it and we're still learning so much too. And then clients, they know best about themselves and their goals. Sometimes as clinicians we can assume that we know what's best and we know what the goals are, but allowing, like I said before, the family and the child where appropriate, or the adult where appropriate, to be a part of that planning and that process can really help humanize the situation and also help them feel a little bit of control over the therapeutic process as well. Okay, musical considerations. My preferred music, I think that's something that we all know. It's the most proven to increase mood, decrease agitation, regulate biological systems. I have a 4-month-old nephew, and I know that I could sing just about any song to him when he's getting fussy, but nothing gets him to calm down as quick as a lullaby rendition of a Lizzo song. Because that's what his mom listened to while she was pregnant with him, and so that's the music that he likes to hear. Therapists should also be very aware of the potential negative effects music can have. Lyrics or even themes in songs, if it's instrumental, can activate cognitive processing, which in turn can risk triggering listeners too. And then choosing music based on the goal, so relaxation, slower. I don't think anyone's really gonna feel super relaxed if they're in a high energy drum circle versus faster percussive music. That's stuff that really hypes people up for engagement or play. And then older children typically tend to focus a little bit better. They can focus better on passive client-directed music compared to the younger kids. I know if I tried to run like a guided meditation with anyone under the age of, let's say like 7, they probably wouldn't be super into it.
I have a question for you.
Yeah.
Okay, so when you look at the ACEs recommendations for like resiliency, they talk a lot about like rhythm and movement. So do you feel like with these considerations, those also have to be taken into, I don't know where they got their recommendations from. So when I look at like their recommendations versus like our musical considerations, do we have to apply those?
Where did you, I don't think I've seen the ACEs recommendation before.
So there were like 3 top ways that they could like improve resiliency.
Okay.
And it talked about rhythm and movement is really 2 of those. So when we think about musical considerations, do we need to consider those factors too?
I think so, because I know that, like I said, it also depends on the goal too, but with movement, a lot of, I know in the research that I've done in continuing ed, it seems like one of the themes of safety is also increasing that physical safety, and so they often don't feel in control of their own bodies, even in some cases. So allowing that expression and that movement, I think, like you said, I think is a great way and something definitely to consider as well. I really appreciate you bringing that up. Okay, cultural competence, something that is constantly learning and ongoing. I think there are so many different cultures out there, not just ethnicities and races, but also generations and identities as well, cultures within disability communities. So it's the development of skills, knowledge, and procedures to provide effective services and how culture may affect traumatic reaction in clients. The one thing I really like to emphasize with this is that we don't generalize, like, oh, this person's identifies with this culture, therefore this is going to be their response to trauma. I think just being aware that that person's culture might impact what their view of trauma is or what their view of treatment is, and working with them to approach it in the best way. Worldview influences also impact how a child views and experiences play and toys. So a child who has experienced poverty and neglect, according to research, is less likely to participate in imaginative play and to think a little bit more concretely as well. Media is also a huge influence on kids' lives and their perceptions of themselves. How many if you work with kids or teens, how many of them have mentioned, oh yeah, I saw this TikTok the other day? Because I'm starting to get that as well. Their perceptions of themselves as well. Creative expressions may include relevant images or phrases, celebrity references, cartoons. Some kids, it might include things like graffiti, gang signs, tattoo art. Music can assist when communication is difficult, but that doesn't mean every approach is going to work. So if the child comes from a family where outward expression of emotions is frowned upon, then the therapist shouldn't push the client to openly express their emotions. Like I mentioned a little earlier, that can be traumatizing for them too. But to assist them in channeling it through other measures such as instrument play or songwriting. Some kids might prefer, improvising and being imaginative. Others might like more structured interventions. It really just depends. We also have to be sensitive to the worldview, beliefs, and preferences of the caregivers. I know that not every client that I work with or their families particularly has the same set of values or background that I do. And so learning from them and being respectful and responsive to their viewpoints, even if it's not necessarily something I agree with. Making parents a part of the process too, if you can, and in a healthy way. And then this, music is a universal phenomenon, however, it's not a universal language. Music varies across different cultures, across the world. I'm from Canada, and I know even though the US and Canada aren't very different, a lot of the music that I grew up listening to is actually quite different than some of the music that I've heard in the States. And also across generations as well. I'm not gonna play 50s music for a 10-year-old who likes hip hop and pop. Okay, so I wanted to kind of do like little group breakouts so you could talk amongst yourself, either in groups of 3 or 5, whoever's around you, and just take a couple minutes to talk about how you implement culturally sensitive care or how you'd like to improve on this area, because I think it's something we can all continually work on. So I'll give you guys a few minutes to do that if you are willing to do so.
That's good.
All right, so as we're wrapping up, is there anyone who is comfortable sharing some of the things that they talked about? Yeah.
One thing we talked about was being careful about making culture like the first thing that you talk about with someone if they're not bringing it up as an issue, because it could create a maybe a thought in the client's head that, oh, I didn't even think that was a thing that you were thinking about. But so I think just being cautious about that is important.
That's great. Thank you so much. It's stressed and culturally sensitive care about being willing to listen and to learn as well. So not, just like you said, not assuming. Yeah?
We kind of talked about how it can be, it's easier the more you practice it. So the more you practice being culturally sensitive and the more you practice implementing practices of asking maybe difficult questions for you, but that can be like door opening questions for a client.
Yeah.
But the more you practice it, the easier it becomes and the more normalizing it feels.
That's so true.
Yeah.
Oh, yeah.
One thing we talked about is that sometimes when you're faced with a type of music that somebody really prefers, especially if it's, a different genre as far as, like I had a Romanian client or someone who spoke only Arabic, sometimes it feels really daunting to learn their music, and so we talk about really starting with rhythms, because that's a place that you can learn the basic rhythms of that, and that way be able to interact with them and ask them to teach us more.
Yeah, I definitely, I really mean, I didn't even think about rhythm in the first place. I know when I was in internship, I told my supervisors about my midway point, like, I'm so nervous to do music from other cultures, not because I think it's like bad music, but because I'm a white woman, I don't want to unintentionally appropriate. And so something that was emphasized was just the willingness to learn and to, you're not going to know everything, and to listen to that client and respect where they're coming from. Okay. Personal considerations. Secondary trauma is a very real thing and is not uncommon among therapists. And always being aware of your own emotions pertaining to the client or the patient's circumstances. It can be really difficult to work with kids who are critically ill in the hospital, who have experienced trauma themselves, but compartmentalizing and making sure that we are not bringing these things into the session, that there's no countertransference. Radical self-care was something I learned last year at AMTA. And the idea is that it's not just enough just to say like, oh, well, today was kind of a long day at work, so I'm gonna go sit in my bathtub with a bath bomb. Oh, that's not lovely. But to always be conscious of your own feelings and your own self-care throughout any day, any experience. I've been seeing a therapist for about 4 years. She is awesome, and I feel like has helped me grow as a clinician too. And it's something that is so essential in my own self-care practice to become, to make sure that I can help my clients by first helping myself. Boundaries. That's something that the other presentation talked to a lot too. It's so essential in trauma-informed care because not only is it important for us, but it's also important for the client. If you're doing everything for them, then it kind of takes away from their own autonomy. And we want them to be able to succeed outside the therapy setting as well. And like I said, it can be very draining on us to feel like we have to do everything. I know I recently had to put the boundary in place that once I get home from the office or home from my drive days, I don't touch my laptop. I don't do work or check my emails or answer phone calls because I found I was staying up trying to work on things, getting too involved in a client's cases. There was one particular case recently where the parents are divorced and would copy me on email chains updating things about their child, and that was great, but then they would start arguing on the email chain, and it's 9 p.m. on a Sunday, and I'm in my pajamas watching Chopped on the couch. So and that was really stressing me out, so that wasn't good for my own health. So letting, in that kind of situation, the parents know that I was there ultimately to support their client, for my client first and foremost. And it's also really good down the line too because it shows the clients that they can set their own boundaries. Exquisite empathy, and that's engagement that's discerning, present, sensitively attuned. Strong boundaries and is heartfelt. It's being very self-aware in the moment and making sure that you're being aware for them as well. And compassion focused. We provide the tools, but the client is there to guide through that journey in their own healing. How many people, if they've lost someone close to them, has heard the phrase, oh, well, they're in a better place, or, oh, they wouldn't want you to be sad. Things that, yep, I'm seeing some hands, me too. See, things that are meant to be kind and to help, but really in the long term can be hurtful and harmful as well. So just being sure that we are compassionate and sitting with people in their feelings, in their grief. I know when I was at Riley, there was one time I was with a mom with a baby who had just withdrawn from care, and I stayed there for 2 hours, and sometimes we talked and sometimes we sang, but mostly I just was with her just in case she needed anything. And that, the team said, was one of the most impactful things for them, just the fact that I was present for her in this awful moment. There are no words that can fix a traumatic situation, so it is appropriate to just say nothing sometimes. Okay, now that I've thrown another big chunk of information at you, do I have any questions? Okay, so family-centered care. So this is an approach that you'll see a lot talked about, especially in pediatric medical settings, But it's also really applicable to other programs that provide services to clients. I know it's something that I use in the waiver. Assisted living facilities as well can use it. So this could include assessment for family risk factors, non-judgmental approach in working with families, which I know can be a very difficult thing, especially if you are aware that there is some sort of unhealthy relationship or abuse inflicted by that particular caregiver. Something I do is if the client has expressed to me of something unhealthy that the parent has done, I always like to give little session reports about like, here's what we did today, and like they did a really great job focusing, but also saying, yeah, I really noticed that they responded well to this chart that I made, or to a quick countdown, or just a break in between interventions. So that's always something to consider, right? Letting them know that there's another strategy too, but not feeling like I'm forcing what I think is best on them. And then advocating for their needs and wants in care as well. Knowing who their supports are, if you can, as well, and then clear and consistent communication between the family and the team. This can make things so much easier and so much smoother, really make them feel like they're a part of the process and in the process of their child's healing or their family member's healing. We're going to take another couple minutes, and so what are some ways that you can implement family-centered practices in your setting? So if you want to chit-chat with your groups again for a few minutes.
I was talking a lot about, I practice in hospice, so I run into a lot of family-centered care. A lot of times I'm there more for the family than the client themselves. So that's something that I do all the time.
Oh yeah.
And it can be really tricky when you run into different needs. Like the client often needs something that the family needs a totally different thing out of you. So it's always an interesting balancing act to figure out.
For sure.
How do we get benefit for everyone?
Yeah.
Anyone else? Yep.
One thought that I just had too was that just sort of keeping in mind that you can't do everything for your patient, and knowing that you have other disciplines that can support the patient's needs. So just keeping that in perspective.
Oh yeah, that's so true. Yeah.
It's just pop. Because I work at a residential facility for youth in care, so ECFS boards, and a lot of them don't have family, don't have that support system, don't have friends outside. So it's, I guess, like what would you do in that situation? I kind of view like the staff, like the therapist as like their social connection, but
I mean, when I was at Riley Hospital, there were a lot of times on the behavioral health unit when I did groups there that the kids didn't really feel any support from the outside as well, and so the topic of family was often a very rough one. I think, encouraging relationships, if you can, or support from the staff, like you said, but also among their peers as well. If there's any way to do supports among them. I'm not sure what the, oh no.
they're very diverse on the
Okay.
parenting and things. They're not very.
That's a really good question. I'm gonna have to think on that one for sure, because I think that can be a tricky thing. Yeah, Rachel?
I have like a thought on that question. It's not an answer, but just a thought. My background's in forensics. I worked at a Supermax for a little while doing music therapy. And they're like, none of them have any family allowed to visit. They've done a lot of things to the point where they've lost like their right to have any contact with the outside. So it is interesting to see how like over the course of a year doing groups with similar people, because their sentences are a little longer. I'm not sure like how long people are at your facility specifically. But through groups and through some of the activities and like gradually opening up the sharing process and encouraging peer feedback, you can create like a sort of family support community setting, even for people who have no family. But it does take a long time. Yeah.
Yeah, I can imagine. Okay. So assessment. Oh, sorry, I forgot. Was there anyone else? Sorry. Okay. Assessment, so comprehensive assessment, like we always do, not just of typical information, but also any risk factors for experiencing a trauma response or ACEs. So this could include previous trauma history, if they've been hospitalized, or previous mental health issues, lack of external support system, or an inability to cope with change procedures. Information can usually be gathered from the client if they're willing to share that, other staff and chart notes. I know at Bridges I get a lot of the information from other rec therapists or behavior therapists, other staff who work with them as well in meetings. And then also assessing for the child's developmental level or the adults, because their responses can vary by age. 0 to 5 tend to show regressive behaviors, things like wetting the bed or tantrums, intense fear of being alone, psychosomatic pain, mimicking the behavior of their caregivers. When I was doing practicum at the domestic violence shelter, I watched this little girl start, asking her mother for something, and her mom said, not now. I think she was 2 years old. And the little girl didn't like that. And so she started, 2 years old, kicking the mom and cursing at her, because that's what she had witnessed her dad do to get what he wanted. So something that to always be aware of as well. 6 to 18 may show some of the behaviors, but also can show things like issues focusing in school, which will often give them the diagnosis of ADHD. Older teens deny symptoms or feel helpless or guilty for what they've experienced in some cases as well. Ooh, I'm missing a slide, but I had for some reason I had a triangle about the levels of care, and so the levels of care were specifically related to trauma-informed care. If you didn't get a program, I'm sorry. I'll talk about this for a sec, and I will definitely email it to you if you want to come up and get that information. And so, gosh, there's 3 stages. Yes, please. I completely blanked. Thank you so much. Okay. So there is universal. So this is a generally well-coping child. Maybe they don't have a trauma history. We can use, a lot more everyday uses of music, education resourcing, depending on, what kind of facility that you're in, and then providing tools for independent adaptive coping as well, things that they can use at home. Targeted is when there's some risk factors present. Interventions address risk factors and foster protective factors as well, so to help them mitigate that trauma response. And then supporting patients or family. I wrote this up when I was in internship, so typically this is talking about the medical setting, but something that you can still use when you're thinking about, like, all right, how into trauma-informed care do I want to get? So for instance, a lot of my kids with the waiver with no trauma history, I usually just do what's at the universal level, whereas some of my teenagers or kids who might have some difficulty with emotional regulation, that's when I go targeted. And then clinical is severe persistent distress, a history of ACEs. That's when I really start to hone in on, like, we are doing trauma-informed interventions for sure at all times to address this and to also mitigate this trauma response that you might experience. Okay, so a neurologic approach to trauma-informed care. The stages of feeling and coping are processed throughout the brain. I'm going to do something that seems a little silly, but bear with me. So I want everyone to raise your hand and make a fist like this. Say, this is my midbrain.
This is my midbrain.
So your midbrain is the most primal function of the body. It is your fight or flight or flee response. When kids or adults are really stressed out, this is where all the thinking goes. Often this is one of the more higher activated levels in traumatized kids. And these things are meant to react quickly to keep you in a high adrenaline state. Because as a clinician I know described it, if you see a bear in the woods, you're not going to go, well, let's see, I can run over to my car, which is parked over there, and then I hopefully can get out. You're just going to go. You're not going to sit and think it out. And then I'm going to put the mic down for this. And then there's your amygdala. So everyone, raise your hands and pinch them. and then put them on the side of your head. Sorry. And say, this is my amygdala. This is my amygdala. Sorry, I needed to get that picture. It was kind of funny, but they're about that size, almond-shaped on the side of your head, and that's the center for emotion as well, often overactivated in traumatized children. Very highly emotional, very reactive. And then last one, take your finger and point it to your forehead and say, this is my prefrontal cortex. So your prefrontal cortex is the center for logic, reasoning, executive functioning. It's not fully developed until you're 25, so I'm 23. I don't even have a fully developed prefrontal cortex yet. And something that is really impacted by trauma and unhealthy experiences as well. Like I mentioned, the majority of thoughts and actions reside in the midbrain, which can cause them to be unresponsive to any sort of rationalization. So as a result, the therapeutic process needs to start from the bottom up. I learned all these fun little hand signals from a teacher at Riley Hospital when I was doing shadowing her on the behavioral health unit. She did this thing called Brain Club, where she would sit down with the kids and talk about different parts of the brain and how the brain is plastic and we can rewire these connections to make good choices. And even though I learned a lot in anatomy, I hadn't actually learned before about how our stress process is bottom up. And I think it was a couple weeks later, I was on my way home and I was super overwhelmed by something that happened that day, and I called my mom. And my mom's awesome, she's super supportive. The first thing she tries to do whenever I'm upset is to rationalize a situation. And I was getting upset, and I was getting frustrated with her, and I went, okay, wait, stop. And I said, hey Mom, my brain is not in the space to process this information right now. I'm not doing with the thinking the part of the brain that focuses on logic. And she went, oh, okay, well, what do you need me to do then? Just need you to sit and listen. Okay. And that was super helpful for me at the age of 22. I can't even imagine how helpful it would be for a kid or a teenager to pick that skill up earlier in life to communicate their feelings. So as music therapists, there's different goals within these parts of the brain. So the midbrain is mainly self-regulation, attention, arousal, and impulsivity by using a variety of structured repetitive activities. I know I have a client I'm going to talk about in a case example who has pretty significant OCD. And one day she got so hyperfixated on the fact her clothes were supposed to be perfect that she tried taking them off in the middle of the session. And so I just had her sitting and breathing with me, and then eventually able to redirect her by handing her a ukulele, and that's an incompatible action. So she was just strumming the ukulele instead of trying to take her clothes off in the middle of the room. Tapping into positive sensory experiences, things that they like. And then the amygdala, the limbic system, relational issues, emotional expression. A lot of what I'll explain to my kids is with emotions. If, let's say we got like a soda pop bottle and we give it a really, really big shake, and I were to take the top off, what would happen? Everywhere, it goes everywhere. And so encouraging the containment of that and not encouraging them not to bottle up their feelings, but to let it out in a safe and healthy way. Because if I just turn the cap a little bit, only the air fizzes out and it's healthy and everything's okay and we're not sticky covered in soda. And then the prefrontal cortex, that return to baseline, you can do more verbal and insight-oriented tasks in that. Okay, so this is kind of a little chart that I've created. Sorry it's not super focused on here. So with the prefrontal cortex, you can do a lot of insight-oriented things like lyric analysis, songwriting. I do a lot of adapted lessons, which is a really unique thing for mastery, especially for trauma-informed care, giving them that sense of, yeah, I did this, and that's great. And then maybe some music-facilitated play for the amygdala or instrument play, familiar music to help regulate these feelings. Sometimes I've used songwriting when they're feeling emotional as well. And then primarily the brainstem or the midbrain is music-assisted relaxation, entrainment, deep breathing, guided imagery, things that will help regulate the system and regulate their vitals so they can come back to baseline. We're gonna try to go quick. Okay, so not only is it essential for professionals to understand how stress and trauma is processed, but it's also really great for our clients to learn it as well. That's a picture of me in my twin sister's 3rd grade class, and when I was done internship, I came home to Arizona to visit her, and got to go in right before their state testing to talk a little bit about, our brains, and because this big stressful thing was coming up, how we could recognize when we were in these different spots of thinking and what we could do in those cases. And they absolutely loved it. My sister, we did this little song together that went, the more I sing this song, this song, this song, the more I sing this song, the better I will feel. And my sister said the next day during testing they were singing that to themselves. We babies. It can, like I said, increase healthy coping skills, a tool to communicate their stress as well. One of the visuals I've got is a brain plan. And so if this is age appropriate, it's something that's really awesome to use. So showing them, I'm feeling good, I'm yellow, I'm feeling uneasy, or my midbrain, I'm feeling really stressed out. What can I do to make myself feel better? And how can I let people know that this is where I'm feeling, this is what I'm thinking right now? So you can take a look at those. I'm gonna do, this one's a little shorter because we're slowly running out of time. How can we give some of our clients, if it's appropriate, an understanding of how stress is processed, either in our brains or ways to communicate when they are feeling stressed out or overwhelmed? Okay, we will keep chugging along. All right, the other key thing in trauma-informed care is encouraging resilience and post-traumatic growth. So post-traumatic growth is the idea that someone can grow and can thrive after an experience. It can cause, feelings of self-worth, and if encouraged properly, can turn into a really positive thing. It should be really encouraged by all clinicians working with the family. And then one of the ways to do that is self-compassion. So compassion is defined as a kindness, a caring, and a willingness to help others. And self-compassion is no different, except it's applied to yourself. So it's a little different from self-esteem. Self-esteem is, things that you're good at, feeling good about yourself, versus self-compassion, which is, there are things that are good about myself, but the things that I am working on, I'm gonna work on because I care about myself. And I care about myself as a human, and I recognize that the things that I need help in or that I could work on are all part of the human experience. I want to work on myself as a person because I care about myself, not because I think I'm a bad human being. So there's self-kindness, common humanity, and then mindfulness all built into that. Okay, so case example I talked about a little earlier, and of course everyone who has case examples in this has signed a release form. So client is a 26-year-old female with a primary diagnosis, so what qualifies her for the waiver, of autism spectrum disorder, and secondary diagnoses of OCD and depression. She's got a trauma history of emotional abuse and parental dysfunction because her mother was alcoholic. And when I first started seeing her, I thought, okay, great, we'll work on some of her receptive communication skills, some coping skills for sure, and then, her self-esteem, because she really struggles with, I have to be perfect. And when her annual came up, I realized, okay, her self-esteem is actually pretty good. I could ask her to name off things that she liked about herself, and she could go on for a while. But it was her self-compassion that was really struggling. If she made a mistake or she felt she wasn't doing something perfectly in the session, she would just totally beat herself up about it and really couldn't fathom a world where she made mistakes. I remember asking her once when we were talking about this, okay, well, what's some, loving kindness that you can tell yourself when you've made a mistake? Oh, I just won't make that mistake again. So we do a lot of self-compassion through meditation, through lyric analysis, songwriting, things that really focus on, being, I am a human, and this is all a part of the human experience, and I don't have to be perfect to be okay as a person as well. Another thing is gratitude practices. Gratitude thinking, this promotes savoring positive life experiences. Now, this isn't like, oh, just ignore all your trauma and be grateful for the things that you've got, because that's not healthy. It's still appreciating the things that you have in life and savoring the positive life experiences you do have. This can build bonds, strengthen relationships. Can be used in lyric analysis, songwriting, meditation. When I was doing my certificate course, they had this really cool little intervention. And they basically said, okay, write a letter to someone who impacted you positively in your childhood and who you never got to thank properly, and then hand deliver it to them in the next week. I'm from Canada, so anyone who impacted me in my childhood, I'm not going to be able to logistically see within the next week. So I went, okay. And then I picked my boss, Caitlin, and I wrote her this letter about how, this is my first job out of college and I was terrified. I had recently lost my grandmother, was feeling like I was at the lowest point in my young life, feeling worried, like I didn't know what I was going to be doing, and she was just so incredibly supportive of me and encouraging, always asking questions, and that was something I really appreciated. And I got to deliver that letter to her in her office, and we both just had like a big cry. It was something that was really special. Definitely something I encourage people to do, whether it's your boss or your friend or your family. It's also, according to the course that I did, shown to decrease depression rates later on. And then forgiveness. Now, this isn't about forgiving the person who has wronged you, but seeking peace and understanding. Forgiving yourself as well. I know that a lot of people carry survivor's guilt or guilt feeling like they're at fault. Oh, I shouldn't have let them abuse me. I should have been stronger about it. Instead of giving into hurt feelings, looking for the beauty, love, and kindness in the world, and really emphasizing that this is truly an act of courage. Okay, I've got a case example again. So this focuses a lot on gratitude. Client's a 13-year-old female with a primary diagnosis of borderline intellectual functioning, secondary diagnoses of post-traumatic stress disorder, reactive attachment disorder, ADHD, and oppositional defiant disorder. She's got a significant trauma history. Neglect, sexual abuse, parental dysfunction, incarceration, and then death. Her parents, unfortunately, both overdosed. And I repeated sexual abuse, but it was extensive, unfortunately. So she got referred to me because of my trauma background. So this includes increasing her positive social interactions, increasing her emotional regulation and coping skills. And so I kind of took that letter writing intervention I got to do and turned it into a song. Let's see if I can play it. This is just a clip from it.
Thank you, family, for having me in your life. When I'm having lonely nights, your support is squad, even when I'm feeling like I'm not close to God. Help me understand what family really is, even on those days don't feel like I have a family.
So that was something really sweet that she wrote and that we put together. One of the things that she really struggles with as a result of her attachment disruptions is being very defensive and just not allowing herself to have these healthy relationships. I did an in-home session with her, and her mom just happened to be, on the phone, just talking. I think it was to DCS, and she was looking at me like, "Oh my God, Miss Katie, isn't she just so annoying?" She's just on the phone. So that was kind of what inspired me to do the gratitude song, to help her to recognize that there are so many positive and supportive people who love her and care for her. And she was so excited to do this, and so excited that her mom got to see this as well, and that she got to express these feelings to them. So, oops, no, okay. Unfortunately, we don't have time for another group breakout. Ooh, we're really running tight on time. So there's not a lot of research on there. I talked a bit about post-traumatic growth, personal strength, appreciation, relation to others, new possibilities. I will send this slideshow out to anyone. And then vicarious resilience is a really cool one. So this is a positive transformation of the therapist's own experiences when engaging with the client. This can include a shift in perception of personal problems, an increased tolerance for frustration, increased sense of effectiveness in your own work, consciousness about race, gender, sexuality, and how all these things impact trauma. Because it is very true, there is a lot of intergenerational trauma that goes on. That's another graphic. I will also send that out. So the moral of this is that trauma-informed care is for everyone. This can be so applicable in every setting, and there's so many amazing things that you can do, whether or not that person has a trauma history. Skip through the last couple slides. So further research is definitely needed, but it could reduce the effect of ACEs and long-term trauma if we start to incorporate this into our sessions and to start really learning about this amazing approach. I think it's something that's, it's incontestable that it's really quite beneficial for just about any setting that you work in. There's a lot more that needs to be done, but I think if we're willing to lead the charge, that this can go a very long way. I'll send some further learning if anyone's interested. I have a lot of references. Does anyone have any questions? That's it for me talking today.
Yay.